smart. And thank you so much for the session. And for the second session now on, I hand over the dais to Dr. Gaurav Pal Singh here. He's here, I think, with us on the session. And before that, I like to introduce our new speaker, Dr. Puneet Kathuria, an eminent prosthodontist and an even more distinguished implantologist. Has Sir joined today with us? Dr. Puneet Kathuria?
Yes, ma'am, very much there. Thank you very much.
So we would like you to be here with us for the presentation ceremony here. We give our e-certificate to our chairpersons, Dr. Guru Raj Rao and Dr. Rajiv Srivastav, sir. Thank you so much here for being here with us and sharing the session with us, sir.
Thank you so much. Thank you so much.
It was a pleasure, and I thank the conference organizing committee for giving us this opportunity. And it was wonderful listening to Rajesh, sir, as usual. It was a very crisp and precise presentation, Rajesh, sir.
So for the next session, we have Dr. Puneet Kathuria as speaker, and he'll be speaking on occlusion and biomechanics. I think these are the two most difficult words in prosthodontics. And we're really scared of till today about occlusion. And he'll be highlighting on those aspects which will make it easier for us in the clinics. And to chair the session, well, we have Dr. Rajesh Sethu Raman with us. Sir needs no introduction. He's spoken so well. We all have gauged his smartness from his presentation only. So, sir, a graduate from GDC Mumbai and postgraduate from Nagpur. He is currently working as the additional dean, professor, head and guide at KM Shah Dental College and Hospital, Barodara Sumandi Vidyapeeth, Gujarat. He has conducted 8 symposia on complete dentures and fixed prosthodontics across the country. He has contributed to a book, Essential Manual of Preclinical Prosthodontics, and has over 40 publications in all indexed national and international journals to his credit. Sir, I welcome you here again to chair the session. And the next chairperson, Dr. Jangla Hari, has not joined us. I was waiting on him actually. We heard him. He's an excellent, distinguished chairperson. And he is now the IPS secretary, joint secretary also. I guess he has not been able to join the session maybe. Dr. Gaurav Pal, so do we need to wait for him or continue with the session?
We can continue because we are very ready.
So that we don't cross our time limit, we'll continue. Exactly. And if he joins in between the session, maybe he has a connectivity issue. If he joins whenever, we'll welcome sir again. So Dr. Puneet Kathuria, I think we'll give the podium to you. And before that, we request Dr. Rajesh to give a brief introduction of a person basically who needs no introduction.
Right. It's an honor that is bestowed upon me by the conference organizing committee to introduce Dr. Puneet Kathuria. A matter of privilege for me, sir, Puneet sir, to chair your session. Dr. Puneet Kathuria did his graduation from the Government Dental College, CGIMS, Rohtak, and Masters in Prosthodontics from Government Dental College, Ahmedabad. So you got a Gujarat connection, sir, with us. Later, he was awarded the Fellow of the International Congress of Oral Implantology, FICOI, for his work in the field of dental implants in the past 20 years. He is an active member of European Academy of Osseointegration. Dr. Puneet has more than 10 years of teaching experience with more than 10 research publications in leading national and international specialty journals. With experience of more than 200 scientific presentations across the country, he is a much sought-after speaker for the leading dental implant company Noble Biocare, for which he is the speaker, trainer, and mentor for the past 12 years. He maintains a successful NABH-accredited multi-specialty dental practice in New Delhi from the past 20 years, with patients spanning from more than 30 countries and experience of placing and restoring more than 5,000 plus implants rehabilitation cases. He is one of the most sought-after speaker and trainer for dental implants. And therefore, the topic very well justified and chosen is implant biomechanics and occlusion, tips for a great implant prosthodontic practice. The podium is all yours, sir. Puneet Kathuria, sir, we present to you.
So first of all, thank you so much, Dr. Rajesh, for a lovely presentation. And at the onset, let me congratulate the whole organizing committee of the 23rd IPS PG convention. And more importantly, the technical committee, which is going behind the scene to make it go so successful. Now, in these troubled times, in these unprecedented times, it's not easy to do all this. So we are all developing ourselves to the new normal. And hats off to you guys to come out and do.
जंगला हरी ने join करा, उनको host enter नहीं करवा रहे हैं, आप check करिएगा please.
So, coming to my topic for today is the implant biomechanics and occlusion, where we go for the tips for a great practice. Now, for all of us who have been into the implantology practice for any number of years, we all understand that once we have done the implants for the patient is kind of married to you for the whole life. Now, they want things which have been done on them, and that too on a little expensive side. They want these things to last long for them, and very justified in that. Now, what makes this implant works longer in the patient's mouth once the rehabilitation has been done? That means once the crown or a bridge has been placed in the patient's mouth. The only criteria which decides how good your prosthesis would last and for how long you would be happy with the patients when it comes to his rehabilitation is biomechanics and occlusion. So this is where we thought, and I also suggested, that let's take up this topic so that if the students are getting, because being a PG convention, if the students are getting into the field of implantology, prosthetics, because being a prosthodontic specialty, they should, from the very first day, they should be able to understand what are the various small things they have to take care and which are totally non-compromising. They have to understand that ways. So that's a topic which I've chosen for everybody today. Now, how many of us, do we ever wonder when we have done the implants, especially multiple implants, do we ever wonder that implants are overloaded? That I wish I have a natural tooth alongside to share the load of the implant? That there are no shear forces acting onto the implants? Are all my anterior forces, especially in the anterior zone, are all leveled in protrusive? Is my dental prosthesis, which I've given to the patient, whether it's a single crown, whether it's a bridge or a full mouth, is in sync with patient's stomatogenetic system, which is the existing system of the patient's mouth? And most important, are we confident enough for a long-term success of our prosthesis? When we do full mouth rehabilitations, we are happy to get these bigger kind of cases. This all happens when we do these work, when we are constantly into implant dentistry for more than 26 years. All of us, I could see very, remarkably talented and experienced people in the jury and in the audience today. And I'm sure all of us have done these kind of cases and many more. So we all understand that with bigger cases comes bigger responsibility. We need to understand that how we would be making our prosthesis last for a longer time so that, yes, patients are happy and we don't have a breakage or a mechanical failure or a biological failure recall of such big, full mouth, full arch, and long span kind of cases. The only thing which is coming important we have to take care is at no given point of time, there should be any excessive loading happening to any of our prostheses. Now, would you believe this, that at our setup, in our practice, once the final prosthesis is delivered, which happens after a lot many steps, but then a special appointment after 48 hours is given for a final check, and another appointment after 7 days is given for a final T-scan analysis of the forces which are acting on these prostheses. The bigger reason being keeping the resiliency part of the soft tissue in mind, because all our prostheses are either designed on a 3D printed model or they are designed on a hard dental stone. But in the mouth, we have the resiliency and light effect, a term called RealF, which we have to take care. And there is always a little adjustment which needs to be catered to when the patient starts using these teeth naturally. So what I would always suggest is, and that's what we always do, that once we have finished our prosthesis delivery, and that too after taking a good care on the occlusion, we always have a recall appointment after 48 hours. And if it's a bigger case again, another appointment after 7 to 10 days, where we try and balance and take care that excessive loading is not happening on our prosthesis. Now, what are the various complications? What are the various prosthetic complications which we can see? Before I mention all the prosthetic complications, and all of us, we have seen these complications. Those who have done the implants, they have seen all those complications in the past. A lot of studies have been done. Another study which I talk about is that 114 cases tested over 8 years have shown that 54% of the patients either had a prosthetic complication for fractured or resin fracture or a ceramic fracture, any kind of complication over an 8-year study, 114 cases. So 54%, that means more than half the patients, what we restore, have always developed complications. Another study shows over 397 implant-supported constructions over 10 years have shown more than 25% of total mechanical or technical complication, which can include ceramic chipping, occlusal screw loosening, or even the loss of retention. And it could be the screw loosening, and it could lead to loss of retention. It could be a cemented interface which is gone and leading to loss of retention. So what we infer out of these studies is that we have to be very careful, and especially for a bigger, long span kind of case, that yes, mechanical and technical complications should not happen, and we should try and minimize this percentage to whatever possibly we can. Now, what are the various biomechanical failures? Now, I can trust on the fact that we have experienced people sitting in the audience today, and they would in sync with me that yes, all of us have seen all of these kind of failures happening. In fact, I may be the only privileged one to even see an implant body fracture happening, and I hope and pray nobody's even seen that. So uncemented prosthesis, very common thing, that the prosthesis in a cement retain comes out, and on the hindsight, to be honest, let's thank God that the prosthesis has uncemented, because that is the first sign of it getting overloaded. Whenever you re-cement back, please make sure you check the centric and the eccentric contacts one more time. And in more than 90% of the cases, you would always find any central or eccentric interference happening, which has led to the cause of uncement prosthesis. Porcelain fractures, we have seen so many times. A lot of times in a bigger cement retain or a screw retain case. If it's a screw retain, yes, it's a little easier to retrieve. But in a cement retain, we are in a fix because the porcelain repair kits have their own limitations. They can help you, but to a limited extent that we can do this, especially if it's a functional cusp. It's very tough to build up without destroying the crown or without remaking the whole crown. Abutment screw loosening, very commonly seen. That's because if we don't tighten, the most commonly used factor where we feel that abutment screw loosening is happening is because at the time of screw tightening, most of us are scared to torque the screw to the company's desirable torque limits. Most of the companies tell you to torque it to about 30 to 35 newtons, but a lot of time we don't even torque to more than 10 to 15 newtons, maybe because of the fear that we may lose the grip of the implant, but that is the prime reason. And on top of it, if it's not biologically or mechanically incomplacent to the stomatokinetic system, the screw loosening is bound to happen. All these things, the last four, are on the major side where we can see the crestal bone loss, we can see the implant failure because of the crestal bone loss, implant component fracture, the screw can fracture, the abutment screw can fracture, the crown on top of it can fracture. And in the worst case scenario, implant body can fracture. And again, I should say that I've seen right from A to Z all these mechanical complications in my 24, 25 years of journey in the field of dental implantology. Now, when we see those kind of complications, what is our objective? Objective is very plain and simple. Let's control the stress around the implants. Number two, let's have a bone implant interface which is prosthetically and biologically acceptable. And number three, that we want a long-term stability of the marginal bone and the prosthesis. That's a simple way. We don't want patients to come back with any failures, whether mechanical or biological. That's the objective, to have the ideal implant prosthesis. In our day-to-day clinical practices, it's very common to see when patients come for a single unit missing teeth in posteriors. It's very common to see anterior aesthetic cases where we do day in and day out these kind of cases. When we have a distal extension based kind of patients where we restore the chewing teeth at the back, whether it's maxilla or mandible, when we try to do full arch rehabilitation, whether it's a maxillary arch or a mandibular arch, where we use a combination and we have multiple missing teeth, where we restore with the help of teeth as well as with the help of implants, or whether we do a full mouth rehabilitation where none of the tooth is present and we have to restore the complete mouth, only one thing matters, and that is biomechanics. If the prosthesis is bigger the prosthesis, the longer the span, higher are the chances of biomechanical failure. So our efforts need to go many-fold when we switch from a single implant to multiple implant to full arch cases. What are the various occlusal considerations which we have to keep in mind? It was beautifully mentioned. We've seen a lot of journals coming, a lot of articles coming on occlusal consideration. One particularly, I really loved it, which was there on 2019. It was saying that the time of loading and the quality of bone has to be kept in mind, of course. We can't load the implants when the bone is fragile, it's not yet healed, or whether it's the posterior maxilla with a D4 kind of bone. We need bone to have its own quality and quantity deciding the time of loading. Please don't commit big moons to your patients by extracting a maxillary molar, putting the implant in the same visit, and rehabilitating and restoring with the final crown in the same visit. That's where we can go wrong. The things can fail. So try and understand the quality of bone vis-a-vis time of loading. Second, location of the implant. The location matters a lot, whether we are doing on mandibular interiors or maxillary posteriors, right from D1 to D4. The more the trabeculae bone we have from D1 to D4, the strength is less, but the turnaround healing time is faster. So depending where we are putting the implant, that's where the leading and the loading time would be decided. Length of cantilever extension, and we would be covering the cantilever as well in my next few slides. That should be kept at minimal, although a lot of studies have shown that if within the permissible physiologic limit and inflammation is minimized in the cantilever, they do work well, leading to less of marginal bone loss rather than the kind of experience we can have if it's not balanced. Parafunctional habits. Now, people do have very funny parafunctional habits and they are not in control of it. Of course, it leads to more of paraxial loading, more parafunctional, more paraxial loading, more loading onto the implants. Premature contacts. That's where we understand that yes, we have to be very sure on removing every eccentric contact, and I will talk about the implant protected occlusion in my coming slides. Morphology of the prosthesis and design of occlusal scheme will also be taken up in my subsequent slide, but that is where we understand the kind of loads which are happening onto the crown would be decided by the morphology and the kind of occlusal scheme we give for that particular crown or the bridge. We are lucky to have advances in the field of implantology where we can use the custom abutments or we can use various abutments which can be customized as per, we can use stock abutments as well as we can use the customized abutment based on our needs based on our gingival formation, based on the submergence of the implant, based on what kind of material we expect in what kind of area. So we are lucky that nowadays every good lab supports customized option, which should be taken up to give you the right kind of results as we expect from ourselves and what our patients expect. With that kind of money being paid, they deserve the best results. So customized options play a very important role in finally finishing up your case. We talk about the customized abutment. We just talked about the customized option, whether it's you choose a cement retained option, which can be even done with a zirconia abutment, or you can go for a zirconia screw retained crown. We do have options in the best of the material. As Dr. Rajesh just mentioned in his previous presentation, the importance of using zirconia, and it has withstood the test of the times, as he mentioned, and very rightly so he said that. Yes, for all of us who are in this field, we understand the importance of zirconia being equally important, whether it's a cement retained option or a screw retained option, especially in the anterior aesthetics cases. And to be honest, nowadays, most of the patients who can afford zirconia, they prefer to go non-black. Non-black means they prefer not to go for the PFM prosthesis. If given a choice by you and by your lab, always give the option of zirconia. Let patient decide. You're only here to give the merit and demerits of each and every technology, what you do. In the cement retained option, even if you're using a cement retained option, although in my practice, if I give you a little heads up about what we used to do about 5-7 years back, we used to do about 75% of cement retained and 25% of screw retained, because that's what the labs were evolving, the materials were evolving, the technology was evolving. That time I didn't have the Cerex scanners to match up with the kind of precision needing for screws. So 75% of the cases used to be cement retained and 25 used to be screw retained. But let me tell you, it's a complete paradigm shift from the past 5 to 6 years, 5 to 7 years, with the advent of latest technologies, digital technologies, which I'm going to be sharing. In fact, I'll show you a live video recording of the case from start to finish, how we do it. And you would see the kind of precision which can be achieved with screw retained. But yes, even if you're doing a cement retained, the most important thing should be kept in mind is the retrievability. If anything goes wrong, you should be able to retrieve the crown. So if it's not interfering in your aesthetic and biological zone, you can try and having a screw axis opening, even for a cement retained, that yes, if anything goes wrong, the whole thing can be retrieved. How to get the correct occlusion in the biomechanics. And for that, we need to understand what kind of forces are acting on top of it. So compressive, tensile, and shear force, we all know about it, that these are the three kind of forces which are acting onto our implants. The bone is always strongest under the compressive force. So these are the desirable forces that we want. 30% weaker under tensile, and of course, 65% of destruction happens because of shear forces happening onto the implants. So compressive forces actually tend to maintain the integrity, whereas tensile and shear tend to disrupt such an interference. We talk about the canine-guided group function and implant protected. We don't need to repeatedly say that it's a PG convention. All our excellent prosthodontic teachers are always been talking about. But a lot of time, I'll just pick up only one case for a canine-guided occlusion. In any young individual, you would always find a canine-guided. As we grow, as we age, the cusp tip of the canine starts getting mellowed down, and the group function starts coming out at the elderly age or a later age. But this kind of funny kind of cases can come in when in a younger individual, you have to give a canine guided, but the missing tooth is also a canine. So that's where, we can, if you see this case on the left and the right, but if you closely check onto the cusp tip of the right canine, which is tooth number 2, 3, you can see when you compare with the tooth number 1, 3, you can see that the cusp tip is being slightly rounded off, very slightly, keeping in mind the aesthetics, the complete functionality of the canine in the aesthetic and the biological zone, still giving the little bit of tweak to have a better occlusal stability onto that, especially in the eccentric zone when there is a canine disocclusion happening. That's where we need to understand how Small efforts, small things will decide the longevity of your implant. Coming to the implant protected occlusion. Now, this is where we all need to understand that, yes, we need to train ourselves. We need to train our labs. Would you believe it? This kind of presentation, couple of slides as a screenshot, we give our labs as the printouts. That yes, this is what we want. We don't want any premature occlusal contact or interference, which is possible only when you do a mounting on a semi-adjustable articulator. There's no point, there is no scope of using a 3-point articulator for a bigger implant prosthetic case. You need to understand, yes, you have to mount, please mount on a semi-adjustable articulator. All our prosthodontists have those articulators. We have 3 of them in our clinic. You know, you can just buy one. You can have various plates so that, yes, the plates can serve as different mounting for different mounting of different patients. But please, from the very first day, since you are into a PG for prosthodontics and it's a PG convention, I insist, I request all of you to have those semi-adjustable articulators where premature occlusal contacts and interference can be taken care. Influence of surface area. We don't want bigger, bulkier crowns. Try to have whatever minimum is needed. Mutually protected. Try to in a longer span case, try to have an articulation which is mutually protected so that the load is not coming onto one implant. It has been shared equally by the number of implants or the number of crowns in the picture. Putting the occlusal load actually starts the way you place the implant. You can't expect axial load on a tilted implant. It will never happen, no matter what. You have to put the implant in the right orientation. Try your best to put the implant in the right position, keeping in mind the occlusal. So I'm sure every good prostho implant surgeon always does a small wax up, a small stent through which a pilot hole drill always happens. That is just to give you the idea that, yes, this is where the central fossa of the future crown or a future bridge would be coming. So let me put the implant as biologically permissibly close to this position as possible. Cantilevers, of course, not a huge deterrent, but yes, to be limited. Golden rule, avoid cantilever. But yes, subsequent slides we'll talk about cantilever as well. Crown height, try and get the right crown height. The minimum acceptable is 1:1. Don't try to make a 20 millimeter height crown over an 8 millimeter implant. It won't last long. But yes, in case you are absolutely stuck with the height of the implant because of the non-availability of the biological factors, try and increase the diameter of the implant so that at least if you're not getting the right height, at least you can try and get the right diameter so that the total implant area kind of able to take up those loads of a higher crown height. Because yes, when the resorption of the bone happens, the bone goes down, the implant is smaller, but the tooth has to be made longer. Keep that in mind. Implant crown contours and cuspal inclines have to be taken care in mind. We don't want bulkier crowns. If you happen to see any good work of any good prostho implant surgeon, you would never see over-contoured crowns. You will always see smarter, sleeker crowns. That's where the implant crown contour plays a very important role. The cuspal inclines and the table width don't need to be very high cuspal inclines, because must understand that with every 10-degree increase of cuspal incline, it leads to 30% extra torque. You have to be very careful. Now, unfortunately, you don't design this. Your lab designs this. So till the time you give a printout of this, sit down with the lab and discuss all these things with the lab. To that extent, I have given the printout in bilingual. Even in Hindi, we have converted this into Hindi and given other printout, because a lot of time the implant assistants or the implant technicians at the clinic, they may not be able to understand completely in English, but when you talk in your local language, whichever preferred language your technician speaks, try and convert it through Google Translate into that. So, and give them a printout, discuss with them, call them once a month to your setup and sit down with them, talk about these small things, what you want as a prosthetic replacement specialist. Always remember, the occlusal table should not increase twice the width of the implant diameter. So in case you are putting a 4.3 millimeter implant, the best you can go buccolingual is not more than 8 to 9 millimeter. But that means in case you need to build up a molar, try and put a thicker implant rather than putting just a very thin implant and trying to build up a good buccolingual diameter, because that all leads to paraxial forces or the transitional forces which are acting on top of it. See the position of the central screw which has come out. Try to be in as central position as possible. And when you have a comparison of the picture on your right hand side, the front one is an implant crown and the natural tooth is right behind it. Please understand, we don't need to make bulky implant crown. If you see the buccolingual width, mesodistal is not in our control. Mesodistal, we have to touch the adjacent tooth. We have to build up the right contacts. But buccolingual is definitely in our control. Try and make it as biologically permissible as possible. If you make too thin of buccal and lingual contours, the tongue from inside and the cheek from outside is going to come inside and patient is going to have a tongue or a cheek biting. But at the same time, you don't want two bulkier crowns coming out from the lingual or from the buccal side. We talk about the cantilevers. The golden rule is, as been said, that yes, avoid cantilever as much as possible, because it not only increases your physiological complications like bone losses, but it can lead to mechanical complications like screw loosening or any other, even screw fractures as well. But then certain times we have to understand that yes, we can't avoid cantilever, especially in full arch implant cases. A lot of time we can finish the implant up to the second premolar, but yes, we have to give them 12 teeth. That means the first molar has to be included in your prosthetic rehabilitation. For that, we need to have a molar coming out as a cantilever. But please understand, lesser the number of implants have shown higher bending forces, and minimum 3 implants when they use for a full arch shows the highest bending force. The distribution of implant, the number of implant has to be considered when you're going for a cantilever extension. A little tip which I can share with you may help you for implant cases is that whenever I'm trying to put the terminal implants, if I'm not getting the right height, I try to put the thickest and the longest anatomically permissible implant, so that even if I have to give a cantilever of a molar, the terminal implant should be the best possible. So try and keep that in your implant planning concentration, that yes, whenever I'm considering to put a full arch, the last implant or the terminal implant, try and put the thickest and the longest anatomically and biologically possible. Because if you're going for a cantilever, you better have a stronger implant at the terminal. A little way of just judging is that yes, take a divider, put it to the terminal abutment, terminal implant, and try to measure the extent of cantilever. A lot of studies, keeping in mind the length of the cantilever, the occlusal force distribution, the number of implants, and the location of implants have shown that implants supporting prostheses with shorter cantilevers have a better outcome and longevity than with a longer ISP. And for all of you who need a figure, the figure for most of the studies have come out, and consensus come out, that not more than 15 millimeters of cantileverage should be given from the terminal implant, from the center of the terminal implant. If you see the slide carefully in the middle picture, I'm measuring the divider right from the center of the screw to the terminal part of the cantilevered abutment. So these are the studies which shows that yes, we can go up to 15 millimeters. And these are the kind of cases. Now, when you see the last implant, always try and pick up that I've tried to put the thickest and the longest anatomically possible, that even if I have to first avoid cantilever, but even if we have to go for a cantilever, it should not be within the permissible range of maximum up to 15 millimeters. And when you actually measure a 15 millimeter, it's like a bulkier premolar. It's not a huge, big, lower first molars. Okay, so try and get into that zone within itself. But again, golden rule for any cantileverages, try as much as possible to avoid it. But it's not that it's the end of the world that if you have a cantileverage, yes, try and get your biomechanical in place when you're doing with cantilever bridge. Just mention about that, yes, all these eccentric forces, especially on the cantilever bridge, has to be reduced on the semi-adjustable articulators before going intraorally. And absolutely, I must say that there is no scope of a 3-point contact of the working cusp in a dynamic occlusion. It's always good for static occlusion. But when it comes to dynamic implant protected occlusion, it is just leads to an interlocking. So you need to remove all these interferences in dynamic occlusion. It's very easy. Then when we do this kind of work and do the planning over the CAD-CAM, all these things can be done on the CAD-CAM and all these occlusal interferences can be removed before shifting to the 3D printed model. We all understand the articulating paper marks, that red and blue have their own significance of centric and eccentric loads happening onto it, but every good practice goes a little beyond that. And I'm sure all good prosthetic implant specialists are using shim stocks where we can have a good molar contact on the 8-micron file, shim stock file. For the molars, they are not able to remove it. When the patient bites on the premolar tightly, then it's the time when they can may be able to remove it with a little bit of pressure, but when it comes to anteriors, it can pull out with the slightest of resistance. So this is a shim stock, what we use as a final check. In fact, I should say a semi-final check, because final check for me happens with digital occlusion. And 2 companies which have come out with these digital occlusions is the T-Scan and Occlusal Sense from Bosch. I personally been using T-Scan for almost about 4 years now, and it's a very invaluable tool for all the kind of cases for full mouth rehabilitation and even for the veneers. The smile makeovers, what we do a lot in our setup, that T-Scan is an integral part to check the eccentric and eccentric loads happening onto the restorations. The kind of pictures what you see, real-time gadgets, they can bring paper marks to life. If you see the picture on the left, this is before, and on the right is after, and the occlusal forces can be very well balanced in the real-time dynamics when we use a digital sensor for a T-scan rather than articulating paper or a shim stock. But yes, it's a gradual way of moving. Number 1, articulating papers from Bosch cannot go beyond 40 microns. Number 2, we reduce it down to 8 microns of shim stock. And number 3 is when the real-time occlusal force dynamic happens when we use a gadget like a T-scan. Take care of this part, the parafunctions. A lot of time patients don't know, they don't tell you various different habits. Yes, 90% of the fracture implant occurs when both parafunctional habit and cantilever prosthesis is in place. Integrally, yes, the lab plays a very important role in your journey for a prosthetic rehabilitation. Try to be at in a very good communication skill with your lab. It's very important to meet them continuously, because yes, we keep on trying to see, interacting alongside with your doctors, with your implant assistants, with your technicians. It's extremely important to see, keep on doing how we are doing, what are our expectations coming out for the prosthesis or the restorations. So when we choose the right restoration, we have to keep these things in mind, that we need to communicate with the lab properly. A lab should be taken up with the preference of his experience in that kind of work. Try to give good impressions or a scan quality. Please understand, please check your work. Restorative options, there are many restorative options which can be given right from single to the full arch cases. Whether you're going with a screw or a cement retained option, or whether the emergence profile in the anterior aesthetic cases is important. And of course, always keep the cost in mind, that yes, we have to make it cost effective to our patients so that we can do more and more that kind of work. All these options for the framework and materials are here. You can take a screenshot, you can talk to your lab. These are the various casted, milled or pressed frameworks, and a lot of veneering options of acrylic, ceramic and composite resins are happening. You can choose the right restoration depending on the kind of financial viability of the case and the need, what best works for that patient. Absolutely no comparison when it comes to casted or milled. The framework accuracy is much better with milled, and so is the weight. Now, very important thing is the milled titanium or a casted framework, they vary a lot in the weight of the prosthesis. The casted with a full arch is almost double the weight of a milled titanium. So try and have the right material of choice, because weight of the prosthesis directly increases the load on the implants. This is my choice of material. Milled titanium framework is what we do for most of for all, in fact, now all our implant prosthetic cases. Coming to the digital part of it, which is the last 10-12 minutes of my presentation, the various options for intraoral scannings are available, and it's just a matter of time that all good clinicians are using or would be using in the near future these technologies to get the better and more precise results and have a better long-term prosthesis. In our clinic, we use the CEREC single visit dentistry a lot of times. We have the CEREC machine, and you can see, and in fact, I'll give you the video as well, which is a 2-minute video. Let me just give you a little picture about the kind of implant. This is the immediate loading, what we call. We got a good Noble Active tooth number 46. We got a torque of almost about 65 newtons, and we decided to go ahead with the case on the single visit. We use the scan bodies, taken the impressions, done the scanning. The lab has done the digital way. They have made a 3D printed model. They've used a universal base abutment, which is the screw retained option for the Noble Biocare, the implants what I use, and the prosthesis in his mind. Now, when you see the prosthesis on the left, you see the kind of screw access hole which is right in the center. Now, that's very important to see. And more important to see is the buccolingual contour of the crown, that yes, we don't need very, very bulky crowns. We just need that right amount of occlusal design so that the forces are controlled. And if you're not happy with the crown on the opposite one, the opposing gauge, you can always tell the patient. Being a single visit patient was on the same day, he was not too keen on the shaping of the upper molar, but yes, the defect can be restored with the upper molar, but we cannot duplicate the discrepancies of the upper to match the lower. Going with the upper implants on the two sides, the two missing teeth, same way, we do a digital scanning, use a scan body, taking the pictures of it. The lab does it on a 3D printed model. They send us the pictures. They send us the 3D printed model along with the screw retained UBA abutment. We fix it in the patient's mouth. And again, you can see the difference on the two, yes, the kind of premolars, what we achieve in the patient's mouth. Now, let me just show you a little video of the presentation of this particular case where we can actually see from start to finish, when the patient comes from a prosthetic phase of the patient, how do we actually check? It's going to be having a music, and I would be doing a little live commentary on the steps of what we are doing here. Remove the healing abutment and check the patient. Testing. With the implant, use the resonance frequency analysis, do the rest, again my check. Ready with the scan. I have correct. Doing the scanning according to taking the opposite approach. Automatically picks it up and create mobile population and the international size. Lab is AM part, head part, when they are billing as per the using a 3D printed model in the sound, and then we are checking the signal in sound with the screw in option. First part of it is the eccentric, and we check the eccentric concepts. Find out that yes, everything is happening. Eccentric part. be high, and that can lead to a premature contact. So always remember, once you have done the filling of the screw access hole, always go back to your articulating papers and check. And this is the final from before and after for the patient. Now, since you have received the crown from the lab, always remember that you have to disinfect the crown which you have received from the lab. Various ways like high pressure steam, sodium hypochlorite, H2O2, or even laser are used to completely disinfect. It's very tough to get a high pressure steam in your clinic, but yes, we use sodium hypochlorite, H2O2, and then we wash it with the distilled water before inserting or even trying out into the patient's mouth, because only a disinfected abutment or a screw or a crown can get the desired soft tissue contours. Otherwise, they interfere, these microflora, they interfere in the soft tissue healing, and you will never get those desired results. So always remember to completely disinfect whatever prosthesis you're receiving from the lab. And this is how we have evolved. I must tell you in the last that yes, we have evolved from freehand. We used to do implants freehand. A lot of time we still do implants, a lot of time free. And most of the time, in fact, we do implants freehand. We shifted to the fact that yes, freehand is not enough. We need to have a prosthetically driven approach that yes, we carve the tooth first and then we put the implant in the best possible biologically acceptable position, which we follow very religiously in almost every case in our clinic. And every good practitioner I know follows this prosthetically driven concept. To help you to that, we had switched over to the static guides, which is the new norm for a lot of clinics, and a lot of people do it. They have those guided surgeries to put the implant in the best possible, keeping the biological as well as the mechanical of the crown in mind before even the planning has happened. And the latest being the dynamic guided navigation system, where we are actually doing the work and you're actually seeing every drill going inside the jawbone like a CBCT kind of stuff. So this is how the prosthetics in implant has evolved from freehand to dynamic guided navigation. Maybe a little picture of this would always help you as a take-home message, as what is we expect out of the occlusal scheme coming out. Narrow occlusal table, reduce cuspal inclines, correction of load directions, reducing the paraxial, which is a non-axial loading, try to reduce the cantilever length or avoid as much as possible, and it always helps to give the implant protected occlusion, as you saw in the video, that yes, we removed all the eccentric contacts and light centric contacts was what it was needed for. With that, I always say that work always very closely with the labs, because they are the ones who will guide you. They are the ones who will discuss with you all the pros and cons in your case, and work always as a team. This is one of our labs which has done this particular case. So with that, again, I take this opportunity to thank one and all who have attended today, and again, thanking the efforts of the organizing committee of the PG convention and the technical team behind to make it go very successful. I request all of you to stay safe, stay happy. Thank you very much.
Thank you, Dr. Puneet Kathuria. And now I welcome you, Dr. Jangla Harisa. I knew you had joined. Yeah. So, sir and Dr. Rajesh Setaraman, please take over.
Rajesh, you want me to move ahead? Rajesh?
Yes, sir. Please. Yes.
Dr. Puneet sir is an excellent presentation, well covered in a short time. We really appreciate the efforts you put on in a short time which you covered. So, a few things was in one slide. I really appreciate the amount of things you covered, where the premature contacts and influence of surface area, cantilever, and crown length, implant ratio, and crown inclinations, cuspal inclination. These things is fantastic, sir. That slide will be probably the essay answer for a lot of postgraduate students, where they can take up with one slide is a lot of answers. So coming to cantilever, I just it's you told it's a larger diameter implant which you choose, whichever is anatomically or physiologically acceptable, the terminal implant. Can you add to that your contact? What is the contact for your preference for your cantilever thing? What kind of a contact extension, contact point or contact area extension, and what is an opposing occlusion will influence on it? This is the one thing which I just want you to add on to it, sir. Second thing is the influence of occlusion in angle. You told very clearly that whatever the angle you placed, going to changing an occlusal forces into a straight is impossible. This is an amazing statement. I really loved it, and it's truly acceptable, sir. But when you talk about a multi-unit abutment and then custom-made abutment and a multi-unit abutment, there is a lot of studies which proven to reduce the occlusal forces, the concept which, because you are a noble mentor, which has started a lot of all-on force with that. So the take-out point of multi-unit abutment and influence of occlusion. These two things you can add, sir, if you want to add something to it.
Why not, sir? Let me answer both these questions, and thank you for, I'm happy that you could make out the kind of efforts we have tried, because being a PG convention, I was always of the impression that, yes, we would be having, esteemed people like you over there who are, well-read people. At the same time, we would be having a crowd which is a younger generation. Now, keeping that the first question in mind, the kind of cantileverage, we always, when I start putting up my implants, for example, if I'm doing an implant in a lower jaw with 6 implants to be in place, I always start with the terminal abutment. I always start with the terminal implant. That's where I don't start with front to back. I always go from back to front, because anatomically possible, as much behind, as much in the posterior, if I'm able to place it, I'm trying to reduce the cantileverage part of it. But since these edentulous patients, they come, and most of the times, we don't get too much of a bone in the first premolar area. So second premolar or first molar area is where we can try and put the implant as a terminal implant. It helps us to reduce the cantileverage span also. Try and put the implant into that position and pick up the implant, which is, for example, if I have a choice to place a 4.3 millimeter versus 5 millimeters, and if I'm reducing the height from 11.5 to 10 millimeters, I would try and pick up a 5 by 10 rather than a 4.3, 11.5. If 11.5 is kind of hindering in my canal placement, it's coming into that zone, which is a little trickier zone. So that's where I try to go from back to front in all my cases, because I want to secure my posterior implant, my posterior loads first before going to the front ones. Coming to the opposing arch, a lot of times when you see our cases, a lot of times we have a complete rehabilitation, which is upper and lower, so things are in control. A lot of times patients have natural teeth, which is still kind of controllable. But if you have certain bulkier prostheses on the top, that's when we have to be understanding that, yes, these are going to be creating extra loading on top of it. We do recommend to correct the opposing arch, but if not, then yes, we have to be doubly sure. If patient is edentulous on the top, mostly he would not be. If he's going for 6 implants on the bottom, there's going to be definitely something on the top. He will not just go with a denture on the top and implant supported 6 implants on the bottom. So that's the kind of dentures give the minimum coming next to the natural, and then the bulkier FPD prosthesis comes the last. Coming to the multi-unit abutments, yes. Multi-unit abutments have come into the place only for the cases where all-on-4 are being done. I personally, we have straight multi-units and angulated multi-units also. But coming to from where I pick up the thing, I would prefer, I am a big fan of trying to keep the things as straight and simple as possible. Only wherever possibly we need to angulate is not my first choice by any means. It's always my last option, not even a choice, I should say, that yes, we are doing all-on-4. We've done a few all-on-4. We have seen angulated implants. We have seen the angulated multi-unit abutments also. But whenever possible, having the straighter implant with a straighter multi-unit is much better. I personally feel more confident enough that yes, my implants are axially inclined to take up the right paraxial force, to take the right axial force and avoid any paraxial force from the opposing arch.
So I had a little query. So there was a slide you had shown where you had implant supported crown for 3.6 and a natural tooth for 3.7.
Yes.
And you had planned that the buccolingual width of implant retained crown be less compared to the natural tooth. Wouldn't that create a step, and would that be a food trap or cause a periodontal problem later?
No, it doesn't. It doesn't, because it is not that big a difference. We are keeping the mesodistal contact in place, and the curve has to be designed in that way that yes, if there is a discrepancy of, let's say, the buccolingual width is 10 millimeters of natural, and I'm putting 4 millimeters or 7 millimeters into the implant, then definitely a 2 millimeter step definitely comes in there. But when we are trying to contour it to as close to the natural, but keeping a little less than the natural, is always, I feel that when it's not needed to go that broader, try to come as close to the natural as possible. But the distal contour and the mesial contour has to be kept in mind. Most important factors. A very valid point that if we reduce the height, if we reduce the width drastically, it creates that L-shaped ledge, and patients keeps on pushing up. And best part is nothing gets stuck in between. But yes, it's a definite food trap if that discrepancy is higher.
Thank you, sir. And that was an excellent session. Yes, sir.
The time lag, then we'll just close. There is one more thing, the last one I just want to put forward, sir. Again, you are very clear that a lot of people now, if there is a more bone, then tilt is the most best option people choosing. You are very clear on your thought, you choose a stride. That is an amazing. I really appreciate on that. And coming to CEREC, because I am an in-lab user, I just want to put forward one. What is your favorite, whether it is a tie base or a custom abutment or a screw retained when it comes to single implant restoration? And point 2 is a contact point which affects an occlusal forces and which causes the bone loss in single unit implant, which people thought it is very easy, but a lot of time we'll see a lot of marginal bone loss. These two things, if you put forward, then we'll just...
Okay, so coming to the prosthetic options, what we have as screw retained is definitely my favorite any which way. So the options what we get from Nobel, and in case I'm using any other system for that matter, are the best possible solutions. We normally give the scanning, we do a soft tissue scanning, we do the scan body scans, and let the lab decide, and we talk about to the lab that what is the best possible options in this particular case, keeping the most important thing, the position where the screw is coming out. Now that is what decides onto the fact that or the occlusal level how it comes out onto that. That's one thing. And I'm sorry, can I get your second question again, please? That
second question is the contact point of any of the single tooth restoration, implant restoration influences as a marginal bone loss, and how would the fit has to be, and what is?
Well, the fit, coming to the fit part of it, of course, everybody's, and we all know about it, that as passive the fit as possible, it's always there. But most of the times when we are doing a screw retained options and we have done the precision of using a CAD-CAM in dentistry, we hardly encounter any such problems, because yes, we get into that, as you saw in the video also, when the screw was getting tightened up with the free hand, it was going perfectly fine. And we always try to get the occlusion in place first before torquing it up to the final screw length. Once it's torqued, finally, we don't try and trust it out, only when we are doing the final screw filling with the flowable composite material. The various points of contacts, which I personally feel when I was doing my post-graduation way back in 95, is that we used to always talk about the 3-point contact of having the right working contacts happening to. That, unfortunately, we carried on. We did it for all our complete denture cases, but that kind of thing in a more dynamic occlusion couldn't find too much of a space, because yes, they were providing more of interlocking to that particular crown or bridge which is happening over there. But yes, the idea is to have minimal occlusal interference. So my intent is for implant protected occlusion is always try and go with a lighter contact on the centric and absolutely no eccentric contact. That's where the best possible marginal preservation, I personally feel, happens, and the kind of results what.
Thank you very much. Rajesh, you want to add anything? Then we'll close probably if you are late.
So, sir, we are already short of time. Thank you so much, Kathuria, sir. It was a pleasure listening to you, and we look forward to listen more in detail whenever it is possible. Thank you so much.
Thank you very much.
Thank you, sir.
Thank you, sir. Thank you. We enjoyed your session.
Thank you.
Here, sir, this is an e-certificate for the chairperson, Dr. Jangla Hari here, sir. And for Dr. Rajesh Seturaman, sir. And thank you, sir, for being here. And Dr. Puneet, once again, I thank you for a wonderful session. I hand over the session now to Dr. Gaurav Pal Singh to continue further.